Now, this is going to help us in a lot of things, but remember, when we're counting with SPECT, one of the things we want to do is correct for scatter. When you start out with a 6% energy resolution, a lot of the scatter is already being rejected without you having to do scatter correction. So you need to start thinking a little differently, and what you're going to see is that everything works synergistically to make the images not only look better, but be more accurate from the concentration point of view. Because one of the strengths of nuclear cardiology is that our pixel value are linearly proportional to the radionuclide concentration, which in perfusion is also proportional to blood flow. Now, so what are you giving up? Well, one of the things you give up is the field of view. As you see, everything is focused on the heart. All the detectors are looking at the heart. So you can see that the field of view in the three different directions is 22 by 25 centimeters, 20 centimeters this way, and 19 centimeters that way. So it's really very similar to a PET scanner. So another reason, when you pay a lot for detectors, the field of view tends to be smaller. But this is pretty, it's quite large. It's difficult, and if I go back to the planar projections here, the detector will actually position the heart for you. So only in very unusual situations with someone who's learning would you get truncation putting the heart out of the field of view. Okay, let's look at some images. So here is a normal patient. Here, using the CardioMD system that we had at Emory from Philips, with a 12-minute stress image and a 14-minute, this is a typo, rest image. And you can see this is quite a nice looking images. There's nothing wrong with these images. But in the same patient with the same dose, which has 30 millicuries for stress, 10 for rest, you can see imaging at 2 minutes of stress, 4 minutes for rest. These are better looking images. So it's 1/5, 1/6 of the time, higher contrast resolution of the chamber, higher contrast and spatial resolution of the myocardium, better uniformity, better separation of the gut activity from the heart because of the higher energy resolution. Now, this is just to show you the normal database that we're using. This is with conventional SPECT cameras, female and male with sestamibi. This is with attenuation corrected, and this is with the Alcyon technology, gender combined without attenuation correction. So in fact, you can see much more homogeneous uptake. Again, making it easier to make the interpretation. Here's another patient. He's an abnormal patient with left circumflex disease. And again, the conventional SPECT, I think we would all agree, beautiful images, right? There's nothing wrong with these images, whether you look at the planars of the tomographic stress versus rest. And you see that there's a defect here in the lateral wall that somewhat improves, again, with the 12-minute stress, 14-minute rest. Look at the discovery system, 2 minutes and 4 minutes. You can see not only the increased contrast resolution, but look at the lesion and look how well it normalizes. So the ischemia is also easier to detect. So all these things are working in your favor. Now, this is a recent paper. In fact, in Denver, it just won the award for the best paper in Journal of Nuclear Cardiology for this year. And this is from the Mount Sinai people. And here what they're showing is, okay, let's start cutting the exposure to the patient by cutting the activity in half, 15 for stress and 5 for rest. What happens if we also cut acquisition time? So this is 3 minutes for stress compared to a 5 minutes for stress, compared to conventional SPECT, 15 minutes. And again, you can see very little difference between 3 minutes and 5 minutes, and significantly superior to conventional SPECT because of the fact that now you're using lower exposure to the patient, lower activity injected in the patient. So you can get both higher throughput and lower dose if you choose to do so. So this is now from the the paper that Fabio Esteves published in the Journal of Nuclear Cardiology in 2010, actually. So, and in our validation for 3 centers, this center in Israel, Rambam, Mayo Clinic, and Emory, you see that reading the conventional SPECT twice, we looked at the reproducibility of the read versus comparing the discovery system versus conventional SPECT. Very similar results, whether there was a defect in the wall or there was the defect was absent or present. And similarly, again, if you go to this, somehow I didn't don't have the slide with the actual publication, but you would see, you can find it and see that also the volumes of the ejection fraction agreed quite well, comparing the 2 different systems in these multi-center trials from the 3 different institutions. Here's an example of what I was talking to you about. This is a lady, 5'3", 206 pounds. I realize these are not the units you use, but this is a short, chubby lady, which I know you. Well, I think in the United States we have a lot more of those than you have here. But you can see the breast shadow over here, and you can see that breast shadow being realized over here. And again, this is conventional doses, conventional acquisition times, conventional SPECT. Now, look what happens when we go to the discovery system. Again, the same setting, it's not that we re-inject or anything like that, same dose, and the 2-minute, 4-minute acquisition time, you see that this reduction of counts in the anterior wall has gone away. Now, I still believe in attenuation correction for a lot of reasons. This machine, by the way, is also quite easy to do prone imaging. And some of you like prone imaging, and if you don't do attenuation correction, I would, because it's so fast, if there's any question for inferior wall problems, you should definitely do prone imaging in those people. But here's a slide from the work of Da Silva back in 2001 in an animal experiment of the in vivo uptake versus the ex vivo after the heart was taken out of the animal and measured on a well counter. And you can see with no correction versus attenuation correction with correction for partial volume effect, which has to do with the resolution of the system, you're getting much truer concentration out of the pixels, but also higher contrast between hypoperfused tissue and normal tissue. And this is from a meta-analysis that I did in 2007, looking at studies from over 1,000 patients, showing the increased gain in specificity and particularly normalcy rate and no loss in sensitivity. So how can you do attenuation correction in these devices? Well, the DigiRad system actually has an X-ray mounted where you can do attenuation correction at that particular time. And the Discover system also has a flavor of it, I believe it's called the 570, that has combined solid state and volumetric CT attached to it. What we do at Emory on every patient right now is we want to get calcium scores on every patient, and we also do an attenuation CT, a transmission CT on every patient. I think eventually we'll be able to use one or the other, we'll have to do both. And then we bring that CT study into the 530C system, and using their software, we align them, and on every patient, we're doing attenuation correction. So you see in this patient, before attenuation correction, there was this region in the base of the inferior wall that could cause some concern. It looks subtle, but why worry about it when you can correct, and it goes totally away with the attenuation correction. All right, so that's enough about hardware. And again, if you want to ask me questions, either right after I finish or while we socialize, we can talk about it. But let's talk about reconstruction, because these machines, all these new machines have new reconstruction techniques. And well, let me not jump there. Let's talk about two concepts, okay? Resolution recovery and noise regularization. And you might think of noise regularization as filtering. You might think as resolution recovery as depth-dependent resolution correction. And it's true, that's what they help with that. But this is truer, a lot truer reconstruction where it's modeling the physics of the system. And so in filter back projections, for example, if you're looking at counts in voxels, and you get so many counts in this voxel, what the software does, the reconstruction algorithm back projects through three-dimensional space those counts. And with the assumption that they came from a radioactive point source over here. But we know if you look at a conventional device, a conventional parallel Hall system, a Hall does not see just this ray, a Hall sees a whole cone of activity. So the reconstruction now, an easy explanation, if instead of back projecting a ray, is back projecting a cone. So this is an assumption, this is reality. And again, everything that's happening now, we're getting closer to the truth in the reconstruction process. Now, we put this together with noise regularization. Let me take you through this example. So here is a vertical long axis image, which actually was filtered, but assume that it wasn't filtered, and I take a count profile across it, and I get this count profile, meaning that this is the region of the normal wall, another normal wall, and there's the perfusion defect. Oops, a little sensitive. And here's where the defect is at. So the conventional approach we've been using for many, many, many years is to apply a filter to these images, the projections, while we're back projecting them, to get rid of the high frequency noise in favor of low frequencies. And this is exactly what the vertical long axis would look like in this particular patient. But look what happens now. Because I'm getting rid of the high frequencies, I also lose the definition of the defect and the contrast of the defect. So I get a very smooth image with low frequencies, but I've lost definition. Now, with noise regularization, it is not filtering. What it is modeling the response of the system, which is specific to the activity and the number of counts that you're getting. And look what happens now. We are replacing the noisy count profile with a smooth count profile, but going through the middle of the count profile. So guess what? We get the smooth response, but we keep the contrast. And you see the contrast here compared to this. This is the same patient, and the contrast here in the chamber compared to that. Oh, and yes, by the way, this was 12 minutes, this was 2 minutes. Okay? So, even if you can't afford the newer fancy detectors, you can afford this reconstruction, this new reconstruction algorithms. And now, all the major companies, Philips, Siemens, General Electric, and Digirad, have different flavors of this type of reconstruction algorithms. And even a company which is a smaller company, Ultra SPECT, actually started promoting this kind of reconstruction algorithms. So a lot of people have implemented this with conventional cameras, and here from the work of Gordon Dupuy, published in 2008, which I then summarized in a review paper in 2011. And here you see an algorithm, this particular, it happens to be wide beam reconstruction from Ultra SPECT, but you can see full time, that is the 12 and 14 minutes filtered back projection with the 30 and 10 millicurie. And you can, again, very nice looking images. But now you can cut the time in half, acquire in half the time with this new reconstruction, same old detectors, and you in fact get higher contrast, better looking static images, better looking gated images.